Thank you everyone for coming, and we have our speaker here with us, Emily, who's going to introduce herself and her topic, so I'll turn it over to her.
Sure. So I'm Emily Armstrong, and thank you so much for having me and coming to listen to me talk about my research today. Hopefully it won't be too dry and will be fairly interesting. I will share my screen shortly as I prepared a presentation. If you do have questions at any time, please feel free to stop me and interrupt me and ask. I have left time at the end though, if you do have any questions that you'd prefer to save till then. But if anything, burning in your brain at any point, just feel free to jump on. So I'm just going to pop my presentation up here for you folks. Just going to do that. So again, Emily Armstrong. So I kept the title short for this one, but I will dive deeper into what exactly my research was. But superficially, it's working with pediatric simulated patients. And to give you a bit of an outline as to what I'll be going through, I'll introduce myself as well as my research and kind of provide you research at a glance. So the methods and methodology will be not too in-depth. If you do have questions about that further, please let me know. I just figured for the sake of time, you might be more interested in the findings that I discovered throughout the exploration. And then I do have a conclusion and some recommendations, considerations for those who might be doing simulation with pediatric simulated patients, or maybe you're not yet. And then again, I have time set aside for questions. And before I get going, I just wanted to put a couple definitions up here in case you are not familiar with what a simulated patient is. It's an individual who's trained to portray the personal history, physical symptoms, etc., of an actual patient. They've been brought in, they've been given a script, told what the objectives are, and things like that. So they're knowledgeable about the simulation occurring. And what I consider a pediatric simulated patient is a healthy child who's coming in to work with, in this case, health education learners in order to provide a valuable, authentic experiential learning opportunity. They can't be trained, so I've taken that part out. The parents that attend with them are typically trained and prepared regarding objectives, learners, the simulation overall. But again, with children, you cannot necessarily train them at certain ages. Other pediatric patients, such as teenagers, you could. But for my research purposes, I am looking more at the 0 to 5-year-old age range. And just to clarify as well, is a lot of people use the term standardized and simulated synonymously, but you'll notice I use simulated throughout. You can't standardize children, just like you can't train them. So specifically, they're what I consider a PSP, a pediatric simulated patient. So to introduce you first to myself, again, Emily Armstrong, simulated patient with, or simulated patient educator, used to be a simulated patient for a long time, simulated patient educator with Dalhousie University Center for Collaborative Clinical Learning and Research. I've been with that team for approximately 7 years now, and as I briefly mentioned, I've actually been a simulated patient since about 13 years of age. And then I attended kinesiology at Dalhousie University and was able to kind of marry my two interests together by becoming a simulated patient educator. I work with a lot of different, or my whole team, our whole team, it's not my team, our whole team, work with a number of different programs and faculties to meet differing simulation needs with simulated patients. And in that time, a lot of my programming has centered around working with pediatric simulated patients and pediatric simulated programs. So that's kind of where my interest in this research stemmed from. And then I decided to complete my Master of Education degree and had to complete or chose to complete some research. And what I decided to do was take my interest in pediatric simulated patients, as well as my need for research, and kind of combine them into creating this research. So to introduce you to the research, Again, the topic rationale really was stemming from my interest in understanding this program a little bit further. In my time working with pediatric programming, I had noticed that many students or learners had attended these sessions with very little previous exposure to children or pediatrics, and they often were anxious and uncomfortable. So I wondered whether these experiences were helping with that discomfort, whether these experiences were adding value to their learning experience, were they beneficial, and what exactly do PSPs play in learners' learning, essentially. And so some of the questions I had, again, are how do they feel about this type of learning opportunity, they being learners, and how do they perceive the role of pediatric simulated patients in their learning? The importance of this research from my perspective is when I went through the literature for my literature review was there's very little research and literature available on the role of pediatric simulated patients and whether people are even working with pediatric simulated patients in this manner. I did find a few preliminary studies or foundational studies that said that their institutions were working with pediatric simulated patients. It didn't dive too deep in why, whether it was working, how those programs were rolling out. And the thing that caught my eye as well was one particular study even said it is not feasible to work with any child under the age of 7. But at Dalhousie, we've been working with children aged 0 to 5 for a number of years from, my perspective as successfully, but I wasn't sure if that was true. And having read that, I had even more questions about the role of pediatric simulated patients, particularly age 0 to 5, in this type of programming. So the purpose of my study was really to kind of foundationally explore the role of pediatric simulated patients in pediatric training for health education learners. And I even went a step further to want to explore their role in the teaching of pediatric communication skills. Often our programs have objectives surrounding pediatric communication, and that can sometimes be tricky to teach with children, especially if they're not at the age of talking. So I wanted to know, how were these experiences impacting our learners, and whether it was positive, negative, or anything in between. So to give you a brief overview of how I completed my research, and I've just kind of kept the purpose there, so it's in the back of our minds, I designed a qualitative research study utilizing kind of a case study approach with interviews. And each interview with each participant was 1 hour in length. I had wanted to complete observation, but I started my research just as the world shut down due to COVID-19 and wasn't able to complete any observation at that time. So again, my role as the researcher in this was a bit as a participant or observer as participant, just because I had those experiences where I've observed the programming over the years and the learners over the years. So I kind of used that as a bit of my own bias in the research and had to acknowledge that throughout the interviews. The participants in my study, I did get 12 in total, which I was very happy with. 5 learners, 2 were specifically from nursing and 3 were from medicine. I was able to recruit 5 parents, so the parents of pediatric simulated patients from our parent taught program, and 2 educators who work within pediatric programming. And then once I collected all my data, I used a preset category approach as well as an emergent category approach to analyze all of the information. I chose to use both approaches mostly because there were particular themes I was looking for due to my previous participation, observation experience with these types of interactions, but I also felt and wanted other themes to emerge from the data that I didn't think I'd be able to anticipate. So I did go through the data with both approaches. For the thematic category approach, so more of that preset category, I looked for themes such as rapport and relationship building, sharing of information, empathy, and of course, pediatric communication skills. So those were things where I asked about qualities that maybe were important to individuals and how those might have been achieved. Some of the interview questions that I asked, just to kind of give you an idea of how the interviews were structured. So first of all, I did use semi-structured interviews for each participant, because I really wanted the participants to tell their story and experiences freely. But again, looking for specific themes, I had some kind of set questions guiding and structuring the interview. And then I wanted to leave room for the participants to, again, kind of share their perspective and views and experiences, and allow a bit more of a conversation to flow and other questions to emerge that I might have wanted to ask clarifying questions or dig a little bit deeper into a specific comment or piece of information a participant had shared. So some of the, just to go back, so some of the questions, I had said I'd give you an example and I didn't, but so some of the questions I did ask were, how do you perceive your interactions and exposure to pediatric simulated patients? How do you feel working with them impacts your pediatric learning? Do you feel that PSPs provide a more authentic learning experience compared to other methods, maybe like a didactic lecture or book? Or mannequins were brought up a number of times as well. What quality skills do you feel are important to pediatric communication, and do you feel that they were achieved throughout these interactions? So that's some of the structured questions. There were a number of others. I asked about each group of about 10 questions or a little bit more. And a lot of the time with the learners, I did really want to explore what they felt their knowledge and skill base was prior to their interactions with pediatric simulated patients, and then what it was following their interactions, which is sometimes difficult because they did have to go back through their minds a little bit. And that's where I had hoped to complete that observation to actually observe the pre and post. But again, as it's impacted lots of areas, COVID-19 didn't allow me to do so for this research. So my findings, there's a number of things I have found, and I will be kind of keeping a little bit more of a nursing focused lens when I go through these. And when I say a nursing focused lens, I've picked the quotes that are from the nursing learners just because that was kind of the intended audience. But I will highlight a few comments made by medical learners, parents, and educators as well. And highlight some of the differences amongst the groups throughout. And before I get started, I just wanted to share that instead of using obviously real names of the participants, since I de-identified all of the information, I assigned pseudonyms to each participant, and they're listed there. You won't see all of the names in the presentation, but in my research thesis, you will see each individual mentioned in it. But again, Catherine and Ethan were the nursing learners, so you'll see them a number of times, and then the other folks are parents or educators or medical learners. And I de-identified the information again, just for what I've noted there, that each participant has the right to remain anonymous. I just removed all of their identifying features from my research. So just to kind of pop up my findings quickly, there was so much information, and I wish I could have done, 3 research purposes for the whole thing, but had to kind of remain focused on the one that I was trying to achieve. There were 4 common and overlapping themes that I discovered, and then 2 what I would consider other areas. And I'll go through each one individually, and again, kind of highlight it with a bit more of a nursing focus, but I will touch on some of the differences amongst the learners, parents, as well as educators throughout, and some sub-themes that did emerge specific to each theme as well as nursing. So the first theme that emerged and was talked about probably the most by the participants is how much the interactions with pediatric simulated patients create a safe learning environment and a place where they're allowed to make mistakes. And I've popped up a quote by Beth, who is a medical learner here. And just to kind of highlight some of the pieces she talked about were safe space to make some mistakes. It solidified that an approach makes sense, and it's a safe space to make initial mistakes. So interestingly, all participants, learners, parents, as well as educators, felt these opportunities provided that opportunity to make mistakes in a safe place where they were able to be guided and supported and not have any kind of critical consequence as they might have in clinical or community practice. And interestingly, as I dug a bit deeper through the information about safe learning environment and allowable mistakes, the role of the educator became more and more important. So each participant really actually commented on that the safe space was created by the presence of an educator in the room, guiding them each step of the way, stopping them when maybe they didn't get wording right or part of a physical exam right. They were there to role model and provide an example before the student or learners had to dive in on their own. And interestingly, the educators mirrored a lot of behaviors that the learners felt were critical to take on themselves. So those would be things like communication, which I'll talk about a bit further, and just kind of manner of being. So interestingly, for kind of a consideration later on as well, is that educators really do play a critical role in these interactions with pediatric simulated patients, and that should be considered when moving forward with these types of simulations. So another comment specifically from a nursing learner who I've named Ethan, just said, a lot of us are really awkward because we've never had to be nurses to real patients. So that's a huge aspect, just getting that initial anxiety out of the way. So yeah, I really wish I had had more experience. And I'll talk to the second part of that quote about more experience shortly as well. So again, it was just that creation of a safe learning environment, making allowable mistakes and getting those initial kind of jitters out of the way. The next theme that emerged was increased learner confidence and comfort and ultimately growth, which again wasn't too shocking from what was available in the literature as well as my own personal observations. You watch learners come in who have very little exposure to children or pediatrics. And as they're entering these simulations, they're quite nervous and anxious. And when they're leaving, you can just almost feel the weight off their shoulders. They look more confident, they look more comfortable, and they have a set approach, as kind of Beth mentioned, a set approach that they're able to go out into clinical and community practice with. So Catherine, a nursing learner, even mentioned it here by saying it's important for us to be introduced to these. And she did add, I don't want to be critical of the school, but I would say that our skills are greatly improved with talking with parents. And I wish we could be doing more directly with children themselves. I think we could really benefit from more of that. So that kind of echoed what Ethan had said as well, of just wanting more experience. And that was kind of a sub-theme that emerged from this. The more that these learners did with pediatric simulated patients, the more they felt comfortable working with them, and the more confident they felt that they'd be able to go and interact with a child, a real patient, and their family on their own, and that they would have that approach to be able to enter those situations in a much more comfortable and prepared manner versus not really understanding the different unique skills that you might need for these types of interactions. So again, just this was actually echoed by Hillary. And interestingly, the medical learners did say they wanted more, but parents and educators actually identified that nurses specifically needed more exposure to pediatric simulated patients, and that's supported by a comment made by Hillary, a parent. I just feel like they don't get enough, especially the nurses. The nurses need more time. So that was an interesting finding, that specifically it wasn't identified that, you know, medicine learners needed more, although the learners themselves identified they wanted more. But other individuals, parents and educators, commented on the need for more for nurses. And that was just really a lot of, the information was more in support of the hands-on experience and getting used to being in the room and navigating those kind of triad dynamics. So this was really what I was looking for in my research, was pediatric communication, and a lot of information emerged regarding this. There were three kind of main areas that working with simulated or pediatric simulated patients assisted in the enhancement of pediatric communication skills. It provided the opportunity for these learners to be generally exposed to pediatric communication. It allowed them the opportunity to learn how to use appropriate language and communication, since often your patients are on different cognitive levels. One medical learner actually said most of their learning is done with adult patients in their first full year, and even kind of throughout their whole education. So they identified that they just didn't even know that pediatric communication was different until they walked in the room, and it was a bit startling to them that they felt that they needed to create a unique skill set, and they weren't prepared for that. They thought they would be able to use all the skills and methods that they had already learned and just adapt it slightly. And what they realized was they really did need to kind of go back to the basics and create a new approach for pediatrics specifically. And also, interestingly, it was highlighted that the nonverbal and paraverbal aspects of communication are extremely important in pediatrics. Although verbal is also important, a lot of patients might be, again, if they're age 0 to 5, those are just the budding years of communication and talking, and you might have a patient that doesn't talk at all yet. So how critical your nonverbal and paraverbal communication becomes when you're interacting with patients like that. And again, here's a comment by Catherine, a nursing learner, who identified, interacting with pediatric simulated patients was beneficial, but just how to get on their level and how to build that trust and relationship and deal with emotions that you might not see outside of pediatrics. So again, just how important pediatric simulated patients are to creating or enhancing an approach to pediatric care and communication that they might not have otherwise been exposed to if they hadn't been exposed to these interactions. Another sub-theme emerged, of course, so much information, but interestingly, the learners in the research, mostly about 3 out of 5 identified as having an average amount of previous experience with children, meaning they had interacted with children a few times, maybe summer camps, babysitting, that sort of thing, family members or friends with children. but hadn't really gone much further than that. One of the participants identified as being a parent themselves and having extensive experience working and being around children. And one learner identified as having none, had never really interacted with a child, had no young children in their family or friends with young children, had never done summer camps as a kind of a teacher or anything like that. So they really felt they had nothing going into these simulations. And even though you had somebody who was a parent and somebody who had no experience at all, each individual found value in these interactions with pediatric simulated patients. They all came away with something. They all came away with better communication, a better approach. They felt more prepared and confident, as they mentioned, and they all walked away with some sort of benefit from interacting with a pediatric simulated patient. And Catherine, who was the individual that had the most experience, said that even as somebody who felt they had a great manner of communicating with children, walked away with a new approach and ways to fine-tune their manner of speaking and their body language, just because it is so unique to pediatric care. So even though they had something already, they found that their skill was better developed through these interactions. Again, Catherine just further went on to say that she learned to be adaptable with her verbal communication, but again, highlighting down below that she learned she had to modify her body language to really try to connect with a patient, regardless of whatever their age was, and how these experiences really exposed and enhanced that aspect of pediatric communication. Ethan also identified I won't call this a sub-theme, but I found it interesting because it was specific to nursing. Medical learners did identify that they do some work with pediatric mannequins. And if you aren't familiar with what a mannequin is a lifelike model that is able to mimic certain features of a real patient, but is not a real patient. And although the medical learners do a little bit with them, the nursing learners identified they do a lot of their pediatric learning with mannequins. And Ethan identified that they felt using the mannequins was helpful. They did add it was helpful for certain aspects that you obviously wouldn't want to put a child through, but working with pediatric simulated patients and how they put it was a real child is better than using the mannequins because they were able to get that communication aspect, which they weren't able to get with the mannequins. Although mannequins can be voiced by somebody through a microphone, they felt it was much more authentic to work with a real child, who had a very specific manner of speaking or manner of moving or anything like that. And as they put it, actually having to calm that child down in person versus a mannequin who's not moving. It was a very unique experience is how they put it, and authentic is how they put it. And it was Ethan who really did identify as wanting more hands-on, and specifically more hands-on with infants. They felt that they weren't necessarily prepared to enter clinical practice or community practice with the skills that they had been given, because they identified as having pretty much no hands-on experience with infants. They were in the room for one simulation, but they didn't actually hold the baby or touch the baby. And this was pre-COVID, they said. So that was something that was interesting that came through their interview. The next common theme that emerged was what I identified as being a family-centered care approach. None of the participants used the term family-centered care, but everything that all educators, all parents, and all learners talked about was something that aligned with a family-centered care approach. So some of the medical learners identified specifically that they were taught a patient-centered care approach, and that didn't quite work for pediatrics, because often there's multiple people in the room who have parents, siblings, sometimes grandparents, sometimes just a babysitter or caregiver, as well as the patient themselves. And it was difficult to navigate that when they had only ever really practiced and been introduced to more of a dyad interview dynamic, so between two people, and now they're faced with this triad plus dynamic in trying to manage and interact with each individual. And one of the learners even identified that it was really difficult to know who to ask the information from, who to gather the history from. And this is also where the role of the educator became really important, because the learners felt that observing a tutor interact in the room was really helpful, because they understood how to mirror, they understood how to manage and respect each individual, to make sure each of the people in the room felt heard and got their story shared without it overwhelming the healthcare provider. The learners did identify that pediatrics, and what I identified as a family-centered care approach, was more detailed than they're used to. They get lots more information because they do have so many people in the room, and they're getting all the information that they don't even need necessarily. So they're getting a lot, and it's identifying what you need to know and what you need to write down and remember. But again, not shutting down a patient from telling their story. And you might think it's obvious, but learners identified how different pediatrics is than adult-only care. And again, they felt that these interactions with pediatric simulated patients and their parents much better prepared them for real life experiences than all the other interactions they'd had with adults. And interestingly, they also mentioned that they were able to carry over some of the skills they learned from pediatrics into other areas of practice. One of the learners specifically said that they had entered a room with a patient and two family members. And because they'd kind of already learned this triad plus dynamic from pediatrics and how to manage each person or work with each person and, you know, have an appropriate line of questioning and each individual being heard, they were able to take that experience and learning from pediatric simulations into that other area of practice. And they felt that they would not have been prepared for that had they not had these interactions with pediatric simulated patients and their parents. So again, just kind of tying back to how much this increased their confidence and comfort prior to going into clinical or community practice. So those are the four common themes that I was able to identify in the research. And two, again, what I called other themes emerged that I really did not anticipate. One was that the pediatric simulated patients and their parents, or well, it was the parent that identified it, but they felt they were actually better prepared to enter the medical or health system with their children in real life, and that they were better able to advocate for their own and their family's health. And I found that interesting because going into the research and completing simulations, we always have the lens on the learner, but we never really explore what our simulated patients or pediatric simulated patients get out of these interactions. And what I identified was they do get a benefit out of interacting with medical or health learners, and that they're better prepared. So what they said was parents felt they were better able to answer questions. They were better prepared to know what information to have prepared. One parent even commented that they finally had all their children's dates of birth down pat. And they said, you know, as much as we should, we don't always have those prepared. So they knew those much better and knew what type of information to anticipate, which actually decreased their anxiety going to meet with a nurse or going to meet with a doctor. And one of the parents identified that they truly discovered what the meaning of care meant. And they advocated for their own health to the point where they actually switched healthcare providers because they didn't feel that they were being respected or heard. And their current healthcare provider provides all of that. And it was through this experience and meeting the, as they put it, the wonderful tutors and learners in these interactions that they realized they weren't having their needs met in real life. And so they made that change. So I found that very interesting. And was kind of like a add-on finding that I loved. And possible changes, every single group, learners, parents, and educators all identified possible changes that they felt would increase the effectiveness or value of these experiential learning opportunities with pediatric simulated patients. I didn't ask about changes, but each individual somehow went there in the conversation when we were having it. And there's lots of different changes that they identified. Specific to medicine, the manner of the rollout of their program is a bit sporadic. As they put it, one individual said it's a complete afterthought, and that they felt that it was fit in just wherever rather than made a specific learning trajectory. So the first quote under possible changes was specifically a medical learner. And they really felt that pediatrics required more attention and more thought to how it was going to be incorporated into their learning, because they felt that they weren't able to take their learning from session 1 over to session 2, since they were spread apart by sometimes a month, they said. And they felt that that was a disservice to their learning. An educator mentioned that 5 sessions for somebody who may be uncomfortable or perhaps doesn't even intend to work with children is a fairly short period of time to try to work through some of that discomfort. So needing more sessions, more exposure, and going back to that sub-theme that I mentioned before, that was highlighted as a possible change as well. Other possible changes were just working with more children of varying ages, more difficult scenarios, as oftentimes one of the learners identified that going into the IWK, emotions run high, the consequences are critical, and being prepared to be yelled at by a parent was their wording, would be helpful for them. So just to conclude what I found in the research, so bringing it back to my purpose, I did find that pediatric simulated patients play a critical role in the development and enhancement of learners' pediatric skills and communication. And that these interactions with pediatric simulated patients, it provides an authentic bridge to real world experience. And that really was the overarching theme, that this really does prepare and allow learners to work through those complexities of pediatric care before going into a real world experience. Some of my recommendations and considerations following my research, and again, just kind of keeping the lens specific to nursing, because that was the intended audience, was that there were three or four, really, I guess, things that I would encourage. First of all, if you're not working with pediatric simulated patients in your health education program, I would highly encourage you to do so. Nursing has already started this, so in a sense, I've given you that check mark. You've already included working with pediatric simulated patients, which is great. The research did identify that it's feasible to work with children aged 0 to 5 years, kind of argumentative to the article I had found, and nursing is doing this. They are working with children aged 0 to 5 years. My other recommendation was to increase pediatric exposure and experiences for those who are already incorporating work with PSPs. And this is kind of across all boards. Well, medicine and nursing were my two focus groups. So for nursing, again, specifically what the learners mentioned is they wanted more hands-on experience. So actually doing physical exams on children and having to take things like vitals on a real individual, so a pediatric simulated patient versus a mannequin. And one of the learners did identify as wanting more interaction with infants. They wanted more sessions and more time overall. They felt the session itself was quite short, and that once they became comfortable, it seemed to be over. And just different scenarios. I did try to dig a little bit deeper into what types of scenarios they might want, but they didn't have any recommendations necessarily, other than they just wanted more. And overall, my recommendation or consideration for that would just be to, for those three things there, add additional sessions, which I know is easier said than done in a already packed curriculum. But it could even just be altering sessions that are already existing with mannequins to actually include working with pediatric simulated patients and their parents. And there's other things that we can always brainstorm on being able to make these happen. And what I would encourage everyone, whether you're already doing programs with pediatric simulated patients or not, is to check in with the learners as well as the parents and educators regarding the value and benefit that might be being achieved or not by the work with pediatric simulated patients, only because this is fairly new and there isn't as much as many guidelines about the work, that we really do need to be continuously checking in with everyone to ensure that these interactions are achieving what we want them to achieve. And yeah, I think future research, just to add something that I do need to look into, or would like to look into actually, is, you know, what is the optimal amount of pediatric exposure? Everybody kept saying more, and I don't know what more is. I don't know where we need to draw the line in the sand, in a sense. And I would like to, in the future, look at the role of the parents and educators a bit deeper, and what they play in these experiences, since they were brought up so frequently. So again, just that real, that bridge to real world experiences was what these pediatric simulated patient interactions provided for the learners, and ultimately they did enhance and provide benefit to pediatric learning. Questions? And I've provided my contact information there, not to put in a plug for the C3LR, or Center for Collaborative Clinical Learning and Research, but creating sessions like this and assisting with the development is kind of what we do. So we are always available and willing to work on these, and you're able to contact either myself or any of my colleagues at the C3LR. We're all a pretty sturdy team and love to work on things and collaborate with individuals. So yeah.
Thank you so much, Emily. So
No
we'll open it up to questions if anyone has any. If you want to turn your cameras on. If you don't mind.
Hello.
Hi.
I have a question. My name's Leanne Picketts. I'm actually a colleague of Emily's. I'm also a simulated patient educator. However, I have never been involved in pediatric programming, nor do I have my own children. So this is all new to me. So Emily, thank you so much for this presentation and for the research that you've done in this area. I think for me, the most interesting finding that came out of this was the idea of contextual learning and the learners being able to apply what they're learning in pediatrics into other contexts. So like you mentioned, you know, the dynamic when there's more than just the patient in the room, other family members, and how a learner would navigate those conversations. I just found that really, really interesting, how the learners can contextually kind of apply that maybe also to maybe working with older SPs and their children or something like that. So that was great. I do have a question. You mentioned that you interviewed educators and that they have a pretty critical role in training with the learners as well. I'm just curious who these educators are. Presumably they're pediatric subject matter experts.
Typically, so one individual specifically works in pediatrics and was coming from more of a tutor background, and one individual works within pediatric simulation generally. So the educators that they mentioned, so the two interviewed did come with some sort of pediatric exposure and experience, but the ones that a lot of the learners were talking about were also pediatric focused, and felt that having that individual with previous knowledge was critical. So not just kind of any tutor thrown into it, but a specialist, a pediatric healthcare provider, essentially. And it was interesting. One of the individuals in the research was the learner mentioned, you watch the tutor outside of the room interacting with the students. And it's, example A. And then they walk into the room and they're completely different. It's example B. And it was very enlightening. I think one of the educators also actually even mentioned this as well, as having observed that happen. And they said it was just so interesting and such a big learning lesson of, okay, now you do need to adapt yourself to be prepared for these situations. So yes, sorry, that was a lot of information to answer.
No, that's great. So they played the role then, I guess they were role modeling behavior, but they were also there as a resource for learners to ask questions.
Exactly. Yeah.
Oh, very cool. Anyways, congratulations on this study. Very, very
Thank
interesting.
you.
Thank you.
Thanks for attending. Any other questions? No, pretty clear. Brianna, yeah.
Sorry, I was also folding laundry and actively listening, so I had to get back to my table.
Yes.
Yeah, so just kind of a note, I am interested that you work with the 0 to 5 age population. And from you had mentioned before during your literature review that there really wasn't much out there. Like, was there anything? Is anybody working with this population, or just not reporting on it? Or
I have no idea. I'm thinking it's a little bit of both. I think that there are people doing the work and aren't talking about it. I mean, even our team, amongst our team at Dalhousie, we know we're doing it, but are we sharing that information to other institutions or programs? We're not right now, realistically. And we've been doing parent taught for a very long time. I think it's like 20 years, and we're not sharing that information or having those conversations. But again, some of the literature just said we choose not to work with anybody below the age of 7. We don't find value or benefit in it. And I was so shocked because here I was trying to look at that specific age range. It also made my heart stop going, maybe we're doing something wrong here. But yeah, so it was interesting. It was just the one article that said we definitely don't work with anybody below the age of 7, but the common theme seemed to be we start working with pediatrics once they're teenagers.
okay, gotcha.
So that was what I found in the literature. I wasn't able to find anything with 0 to 5 specifically, realistically. Yeah.
It's so great because I am based out of Prince Edward Island, and I currently work with UPEI.
Yeah.
And I know here, because PEI, a lot of our kids in the hospital system, if they're sick enough, they go to the IWK.
Yeah.
Right. So a lot of, I think this idea of having pediatric simulated patients would get a lot of, because sometimes our students will go on rotation and might not see, there'll be like 5 students to 1 patient. They're just not there, which is great. We're happy either they're getting the amount of care that they need at a tertiary center, or they're not sick. That's the goal. But having these kind of like really valuable, more real world experiences, like what you've described, I think could be really good. And especially that infant population too, because I've seen it a lot where students will go and they'll see a baby for the first time and not know how to talk to the parent in relation to their, like, sometimes hour-old baby or something. So yeah, this is super, super valuable, and it is different experience than the mannequin scenarios like you had shared. So thank you for sharing this research. You're sharing what you're doing at the center and your own research. So I really appreciate it. Yeah,
you're welcome. Well, and if you ever want to know how we've done our pediatric programming, again, my information was there. I can type it in or anything like that as well, but please feel free to reach out to us. Excellent.
I'll be, or if not me, a colleague for sure. I'm going to have to line your contact. Okay,
excellent. Wonderful. Any other questions?
Do we have any other questions? I don't think so.
Danielle?
Hi.
Hi. How was your
Not so much a question, just an overall comment. My reason for actually attending, Emily, your talk and presenting your literature was we are started to incorporate, and we have over the past few years, incorporate children into our simulations. And Paula, one of my colleagues, is online as well. And so, you know, we were wondering what's the best practices related to getting them all trained up. And obviously you can't train them. But again, you know, just recognizing that they come with that ambiguity of content and to help with that contextual piece of that simulation, which is fabulous. So that if they cry all the time, then the student needs to work through that particular situation. So, you know, much like what I think Brianna was mentioning, that, you know, just the overall exposure will help with getting a little bit more comfortable, even though we know not all nurses go into pediatrics. So, which is great. So from my perspective, you know, we're looking to perhaps tap into you guys from SP at Educators virtually from a Yarmouth perspective. So, you know, and so we haven't figured out all the logistics of that yet, but I hope to see you soon in terms of reviewing some of our content. Yeah, great.
Yeah, that would be great. I mean, even in my 7 years working with the Parent Talk program, it's become something, it's grown. It's becoming much more robust, and we are creating these guidelines that we didn't know we needed, and now we do. And creating those so that we are able to share that information. And to be transparent, I had hoped in my research to interview some learners from speech language pathology and audiology, as they just recently started working with pediatric simulated patients in the last 2 years. So medicine and nursing have been doing this work for a number of years already, but so their learners are a bit more, I mean, they walk in with whatever experience they've had, but they know it's coming. Whereas these are much more newer learners, and they didn't know that it would necessarily be input into their curriculum. So I was hoping to interview them to understand their perspective of the value added as well for them. But yeah, the contextual learning was huge. And I think there's more research to be done there, especially with how little is available already. You know, some of the parents commented that the tutors would kind of hands up and go, "This is real pediatrics, folks. You got to figure out how to get that child on the exam table and palpate their belly." And they kind of just, you know, this is it. This is what it's going to be like. So this is as authentic as it's going to get.
Yeah.
And to speak to your point, I think also, yeah, like children are not trainable. You can prepare them, is how I say. You can prepare them for the interactions, and that's kind of how we put it. And we work with the parents because each child is unique in how they need to be prepared. And then we do train the parents, so they have a bit more context into what they're walking into and what they need to be prepared for. And one of the learners identified that was huge. They actually felt more comfortable knowing the parents knew they were coming in for this reason versus going out into a clinical experience. And oftentimes it's just quickly asked, "Hey, can you see a student? Do you mind if they, you know, ask you a few questions?" And they feel it's sometimes uncomfortable because these parents are there with real sick children and they're being thrown a student. And so they felt that these were better and that the parents were, you know, coming in with that context and preparation. So yeah, it's huge.
A little bit safer for the learning too.
Yeah, and safer for patients overall as well.
Yeah,
absolutely.
Excellent. Well, thank you very much.
Yeah, thank you. I hope your soup was delicious.
Oh, yes.
Are there anybody else have a question? No?
Yes, next research project, all of them. I think it's added to my list, this research, rather than satisfied. Yeah. Well, my email is there, my contact information, if, oh, thank you. I try to make it as calming as possible when sometimes the information can be a little anxiety invoking. So thank you for that comment, Brianna. But yeah, my contact information is there. Please feel free to reach out with any questions. I should have included the contact information for the C3LR generally as well, but I can actually post that in the chat if that would be helpful. Again, a number of colleagues work on the pediatric programming with me and would be happy to assist you with that as well. Again, to just be transparent, I'm on leave for the next 2 months, but I'll be back in January and ready to hit the ground running. So just research, grab that information. It's my typing. You think I would have it memorized? And I do not. Oh, of course, Leanne, prepared with the information. That's our general email. If you do prefer phone, I was going to put our phone number there as well. And in the chat is the phone number if you prefer. I mean, everybody's so used to email and virtual these days. I think phones are kind of last option, but it is there if you want it.
And there's another comment. Can't wait to read this as a publication. Great. Thank you so much for your presentation.
No problem. Thank you.
And the link, we'll be putting the recording on the website, so the link will be there for those that missed it and if you want to tell anybody about it. So thank you so much, everybody, for coming. Yeah. Thank you, Emily.
Thank you so much. Have a great day.
Thank you very much. Have a good day, everyone.
Bye.